Hello friends, welcome back to my channel with a new video, and this particular video is the part 3 of the sedation analgesia series. In the last video, as you remember, we discussed in detail about various sedative agents which are commonly used in the critical care practice. In this particular video, we will discuss about how to monitor and what are the different scales. So this is a very famous scale, Richmond agitation and sedation scale. As you could see that when the score is positive, it is more and more combative. So +4 is a combative patient, +3 is a agitated patient. I mean very agitated patient, +2 is agitated, +1 is restless. 0 is alert and calm, and actually we want maybe somewhere who is between 0 and -1. -1 is drowsy. So maybe 0 is the one which we should target and who actually spontaneously pays attention to the caregiver. So -2 becomes light sedation, -3 is moderate, -4 is deep sedation, and -5 is of course non-arousable. So it is very clear that RASS should be say around 0, and so this is particularly related to the depth of sedation. So if it is light sedation, then definitely there will be decrease in the duration of mechanical ventilation, and of course decrease in the length of the stay of the patient in ICU, where the evidence is grade 1B, and you monitor the depth of sedation by RASS, which we just now discussed. And so here we know that 0 is alert and calm, and of course +4 is agitated, is too much of a agitated or a combative patient, and -5 is not arousable. So we don't want -5, -4, we don't want +4 also, we want 0. So these are the same PAD guidelines, CCM 2013, and which used the Richmond agitation sedation scale, or a RASS, and SAS, or a sedation agitation scale, and they are the most valid and the reliable the sedation assessment tools. And of course the choice of sedation, as we discussed, and I discussed it in my last video as to what kind of strategies I would probably personally used based on the evidences, is of course I would probably start with a fentanyl, which I'm quite fond of because of the opioid analgesic effect plus the sedative effect. I would probably supplement it with dexmedetomidine if the bradycardia is not the concern, plus or minus midazolam in a situation where if I am not able to have that control and if I need a little more degree of sedation. And of course, the ketamine, the dissociative anesthetic agent, ketamine, which we discussed. So, by and large, non-benzodiazepine sedative propofol or dexmedetomidine, and then of course benzodiazepine in few situations, which is +2B, ketamine as I discussed, fentanyl as I discussed as a agent. So these are the current practices of mobilization, analgesia, relaxants, and sedation in Indian ICU. So this was a survey which was conducted by ISSM, our own society, and it was a Delphi sedation survey methodology, which was an online survey conducted with the help of a full-time or a part-time intensivist from 1st of July 2012 to 1st of Jan 2013, so with a period of about 6 months. And what did they found? Uh, so this was termed as a Mars survey, and this was a key finding, and they were quite surprising, which was a contrary to the concepts what we are discussing. So there was a low compliance to the guidelines. This was observed, and 95% of the patients in ICU were given benzodiazepine, and we are discussing about less and less benzodiazepines, right? Uh, of course, the analgesia first sedation concept was non-existing, and I think I cannot imagine, because it was somewhere in 2013, so we're talking about 12 years ago, but still we had a concept of analgesia first sedation which was not followed. Delirium which was unrecognized in about less than 10% of the patients. Monitoring as regards sedation, analgesia, and delirium were low, and the the validation or the recommended scales which we discussed, the RAS or the SAS scales, were not used, or they were rarely used. And today I recommend that you need to have a RAS scale displayed in each and every ICU, preferably in the each and the every cubicle of the ICU of your hospital. And of course, the early mobilization, there was the there was a problem of awareness and the benefits of the same, and there was less and less implementation of the same. So if you look at about, say, decade ago, we were probably indulging into not a very good sedation and analgesia practices. So the take home message for this particular slide I would like to give is, all the things which you can read here, we need to do it exactly opposite of what is being mentioned here. And we will discuss a bit of delirium in my next video, so which is a part 4 video. And of course, so this is a very important slide, and this is a MARS survey, which is, MARS stands for mobilization, analgesia, relaxants, and sedation survey. So I think I will stop here. uh, we will meet in the next video, that is a part 4, uh, uh, which will talk about delirium. So that's all for now. Tata, goodbye, take care.